We'll get started with today's topic, which is on calcaneal fractures. We are going to study how we are going to use or manage calcaneal fractures. Now, my conflicts of interest, none, but I do wish to thank both us, Eotrauma, Dave Townsend and Murthy, who allowed me to share some of the slides. Now, the commonest scenario that will be asked if you're appearing for the FRCS Orth exam, or else in real life as well, when you're called by HENE to answer a question like about the management of a patient with calcaneal fracture. So let's give you a typical scenario. A young gentleman, normal BMI, non-smoker, occupation IT technician who falls off a height and has got a calcaneal fracture. So of these, you will generally need to have a CT scan if they are intra-articular fractures to ascertain whether or not you want to manage them conservatively or operatively. Now, in this typical scenario is quite controversial because of the evidence behind management of these fractures. We will come to this scenario again, but for now, in your mind, please think about which management option would you prefer for this patient, whether it will be conservative or operative. And if we change the scenario slightly to this patient, who's again a young laborer, but he was running away from police, he fell from a height, IV drug abuser, and has got a very swollen and blistered heel. How would you manage this patient, whether you would manage him conservatively or operatively? Fine. So today's session, what we need to learn is some of the anatomy of calcaneal fractures, the epidemiology, decision-making whether we would operate on them or not, and if we do operate on them, what will be our surgical technique or approach. First of all, you need to learn a bit about the calcaneum. What I train my trainees to do is, if at all you're going to manage calcaneal fracture, either operatively or non-operatively, you should get a bone model, a foot model next to you, because like the pelvis, it is very complex and it helps you try and understand which surfaces are involved and where are the fracture lines. So if we notice, the lateral side of the calcaneum is the flat surface, and that is where most of the calcaneal fractures are opposed from. Whenever you get a calcaneal fracture, you generally get a lateral wall blowout. Now, if we come to the medial surface, the hallmark is this process, which is the sustentaculum tali, which then suspends the talus head. So it forms the triangular ligament there, spring ligament, on which the talar head is suspended. Behind the sustentaculum tali, you get all the flexor tendons of the foot, which then also are responsible for all the movements in the toes as well as the foot, hind foot joints. Now, in between those runs the posterior tibial artery, and the main blood supply of the calcaneum is through perforating branches of the posterior tibial artery. Some of it comes from the lateral side, i.e. the peroneal artery. So, and the neurovascular bundle is just behind the sustentaculum tali. If we go through the articular surfaces of the calcaneum, you've got the posterior facet, which is the subtalar joint. You've got the middle facet as well as the calcaneocuboid joint. Now, there are certain things that you should know when you are dealing with calcaneal fractures. One is the Bowler's angle, which is normally 20 to 40 degrees, which is calculated by drawing lines between the most superior aspect of the posterior process of calcaneum, the superior aspect of the posterior facet, and the anterior process. This is generally 20 to 40 degrees. The other angle which is measured is the Gissane's angle, which is the angle between the posterior facet and the line joining it to the anterior process of the calcaneum. It is normally around 120 to 145 degrees. Now, the next thing is the epidemiology. It is one of the commonest foot fractures. About 75% of the foot fractures involve the calcaneum. And about 1 to 2% of these fractures overall. Now, the commonest scenario is males, laborers, as well as patients who generally have a poor prognosis are the ones who have a workers' compensation benefit underlying that. Commonly, it takes a very, very long time for them to regain ability to go back to work. They generally start with light duties at around 4 months and back to normal duties about 6 months after the injury. So whenever you see a patient, that should be consulted with when you make decisions about how to manage. Now, these fractures are very commonly associated with other injuries, i.e. sometimes you can have dorsolumbar junction fractures, which with or without neurology. So whenever you see a patient with a calcaneal fracture, you should follow the ATLS protocol and do a complete primary and secondary survey. They can be a part of a polytrauma, which can then distract you of the calcaneal fracture injury. And sometimes they can be also associated with bilateral calcaneal fractures. Now, the important aspect of their management is attention to the soft tissues. As you can see, sometimes you can have large blisters in those areas, and that can affect your prognosis and your management option. Now, the other thing that you need to be aware of when you have a calcaneal fracture patient is the mechanics of the heel, the subtalar joint are all disrupted. So they have a high risk of developing arthritis in the subtalar joint and possibly the calcaneocuboid joint. They also get affection of the plantar fat pad. The way I reckon and I explain to my patients in a comminuted calcaneal fracture is that if you smash a Weetabix, the way it explodes into multiple pieces is what something similar happens in the calcaneal fracture. And the plantar fat pad, I akin it to a bubble wrap. If you break all the bubbles of a bubble wrap, it is ineffective. Similarly, when you get a calcaneal fracture, you can bleed into those plantar fat pad locules, making it very, very ineffective. Now, when you come to calcaneal fractures, the way or the most common mechanism of injury is fall from height. And when that happens, you get shearing forces, i.e. the body weight pushing downwards. And when you impact the heel on the ground, there is a ground reaction force going upwards. And then that results in that shear force, which causes the primary fracture line across the subtalar joint. Secondly, if the force is more, you can develop secondary fracture lines, which can exit just behind the posterior facet, which is called the joint depression type of fracture, or it can extend up to the posterior aspect of the calcaneum, which is the tongue depression type of a fracture. Now, the warning sign for this tongue depression type of fracture, if the tuberosity is avulsed, that area of the skin can lose blood supply. Initially, it will be blanched and then it can necrose. This is one of the surgical emergencies. So please pay attention to this area of the soft tissues. And you've got a displaced tuberosity fracture with compromised skin, it needs urgent attention. Now, the commonest classification used for calcaneal fractures is the Sanders classification. It involves the most broadest part of the subtalar joint in the coronal views, and depending amount of comminution in that posterior facet area is the classification basis. Now, undisplaced is grade 1. If there are two major chunks like this one, then it's Saunders 2. If there are three major chunks, Saunders 3. And if there are more than 3, it becomes Saunders 4. As you can see, the more the degree of comminution in the posterior facet, the poorer the prognosis because of the extent of articular damage. Now, when we decide to operate or non-operate, i.e. manage the calcaneal fracture, there can be conservative or operative measures. We go back to evidence-based medicine. We have various publications of randomized controlled trials, the biggest one being from Buckley, which had more than 200 patients in either group, and they showed no difference in the functional outcomes between operative and non-operative management. Although when they did subgroup analysis, they found poor prognosis in males and as well as patients who have workers' compensations involved. Then the biggest trial that you need to know for your exam is the UK HEAL trial, which again showed that there is no significant differences between the outcomes of operative and non-operative management, although the complications are much higher after surgery. Looking at long-term results, we've got evidence again to show that operative management is not superior in the short term, but slightly beneficial in the long term. Now, the main thing that you need to know for the exam is the UK HEAL trial, which was a pragmatic, multi-centered trial involving 22 hospitals. The only exclusions that they did were open fractures and severe deformities, including varus valgus and calcaneofibular impingement. They had 151 patients randomized into the two groups, and they found that there was no difference in the primary outcomes after operative or non-operative management. They had a fantastic follow-up of 95%. They found that the complications were much higher and reoperations were more common in those who were operated on. There was a high rate of wound complications, 20%. This made the headlines in BMJ, where it said surgery provides no benefits to calcaneal fractures. Now, if we go back to our scenario, where we've got a young, cooperative, working patient who's a non-smoker, not much of soft tissue injury involved, do we still operate on him or do we manage him conservatively? Because the UK HEAL trial says that there is no benefit, but I feel that I can make him better with an operation. So how do we do that? Now, if we look into the UK HEAL trial and we critically appraise it, we find that only 30% of the patients who were eligible for the trial were recruited, which explains, which causes a lot of selection bias, i.e. if I felt that this patient would benefit from surgery, I would not recruit him for the trial. In the ones where I'm confused that they would not do well either way, then they would be recruited to the trial. But that's my personal opinion. The second one was that they had only used an extended lateral approach, which is known to have high wound complication rates. Now, in my books, the cases where I would think of surgical option, especially if the patient is compliant and non-smoker, would be where there is a lateral wall blowout causing a calcaneofibular impingement, or if there is significant depression of the articular surface, but it's not very comminuted. Secondly, it'll be a widened heel with deformities, either significant varus or valgus. Now, if we come to this scenario where we've got a young cooperative patient with the joint depression and with the soft tissues permeable for operative intervention, how would we approach it? Now, whenever we do decide to have an operation for a calcaneal fracture, what do we need to achieve? We need to restore the mechanics, that is the length alignment rotation, in which in calcaneal fracture cases would be to restore the calcaneal height, the calcaneal varus, get the tuberosity fragment controlled, and restore the articular surface of the subtalar joint. Now, the gold standard for calcaneal fracture fixation is the extended lateral approach, which was described by Roger Atkins in 1992, which raises a full thickness flap from the lateral side of the heel and then approaching the subtalar joint. Now, when we do that, the words of caution are go along the line where the skin color changes, posteriorly as go just lateral to the tendoachilles. At both the ends of the wound, please be cautious of the sural nerve. Develop flaps which are subperiosteal, i.e. from your incision directly go onto the bone and elevate the whole flap from the calcaneal subperiosteally. Beware of the peroneal tendons as you extend more proximally, elevate them off before you can reach the subtalar joint. The soft tissue retraction is generally by K-wires which are bent over, and remember to not retract unless you have to, and make sure that you approximate those edges perfectly and with non-interrupted sutures. Sorry, interrupted sutures, not continuous sutures. The disadvantages of the extended lateral approach is a very high rate, 16 to 25% of soft tissue problems, which can be disastrous. The other approaches which are commonly used are the sinus tarsi approach, which is similar to what you would do for a subtalar joint fusion, i.e. from the tip of the lateral malleolus to the base of the fourth metatarsal, going between the branches of the peroneal artery, going through the sinus tarsi fat pad, elevating off the extensor digitorum brevis, and then looking at the subtalar joint through that. Now, you will have to use indirect methods to get the calcaneal fracture reduced, although you can reduce the subtalar surface under vision. Similar techniques are used for arthroscopic assisted, where you would reduce the articular surface by assistance from the arthroscope and use indirect measures to reduce the calcaneal tuberosity fragment. These lesser invasive methods have shown a slightly lesser rate of wound complications compared to the extended lateral approach. There's evidence to show that the wound complication rate is much lower in the sinus tarsi approach compared to the extensile lateral, but the word of caution is the sinus tarsi approach is not extensile. You're using indirect methods to reduce the calcaneum height and the varus valgus deformity, and using the sinus tarsi approach mainly to restore the subtalar articular surface. Now, if we go and approach this, whether it's through any of the approaches, i.e. sinus tarsi, extended lateral, or the subtalar, or the arthroscopic assisted, the first technique that I use is a spike or a shank pin in the tuberosity fragment to disimpact the fracture, give traction, restore the calcaneal height. So essentially this fragment, we would push it down to restore the calcaneal height. Second thing what we do is restore the articular surface. So which we do by elevating the articular surface, either using a periosteal elevator or a laminar spreader. In this case, you would use the talus as your template, similar to what you used to use in a tibial plateau fracture, where you use the femoral condyles as a template. You would then elevate this the joint depression type of joint fragment upwards to make it congruous again with the talar articular surface. If you do it, if you see the same things in the coronal sections, what you would do effectively is disimpact the posterior tuberosity fragment, and you would then elevate the articular surface up. You would then fix these two big fragments onto the constant fragment, which is the sustentaculum tali fragment, using any of the methods like compression screws or positional screws to hold the two fragments onto the sustentaculum tali fragment. Now, the aims would be to restore the calcaneal height, correct the varus, restore the tuberosity fragment control, and restore the subtalar articular surface. You need to knit those three bony fragments in some form of fixation, i.e. the sustentaculum tali, the posterior facet fragments, as well as the posterior tuberosity fragments. Whether you use plates, screws, or other methods, it doesn't matter. The important thing is to restore the Bowler's angle, which is generally reversed to normal, and to restore the Gissane's angle back to normal if possible. Now, you should also try and correct the calcaneal width. Otherwise, patient will end up having a broad heel, which makes footwear very difficult. Now, the take-home messages are, it is important to select your patients judiciously. They need to be compliant. They need to be preferably quit smoking, and they should be reliable with your post-operative protocol. Because if they develop any of the complications like the wound problems, compliance is extremely important to get some good benefits out of it. They should best be done by people who have expertise in them, and the timing is important. The timing in cases of the extended lateral approach should be when you can see skin wrinkling around the area of approach. In sinus tarsi approach, we generally can intervene much more quickly, i.e. between the first 2-3 days preferably, because it becomes extremely difficult in a sinus tarsi approach to reduce the fragments after 10 to 14 days. That would then also determine your approach, whichever you have expertise in and whatever the soft tissues allow you to do. So in a sense, you need to restore the calcaneal height, correct the heel varus, reduce the tuberosity fragments back and control them, and restore the subtalar articular surface. You need to read about the UK heel trial, and the article that I've mentioned in this slide is a good comprehensive review. If there is only one article that you need to read, this is a good one, which gives you the brief overview of calcaneal fracture management. Thank you.